Although tricuspid stenosis is quite uncommon in Europe and in developed countries, it's a quite common disease in developing countries. Therefore, it's important to have an overview for the evaluation and how to evaluate tricuspid stenosis.
I will present you the case of a young boy with an history of rheumatic fever. 1 year ago, I started complaining of shortness of breath on exertion, and just a few weeks ago, I complained of irregular heartbeat during the day. So let's start the examination with the parasternal long axis view. Of course, you don't see the tricuspid valve, but you can already see some mitral stenosis. Indeed, when you have a look at patient with rheumatic fever, you see frequently the involvement of several valves. But now let's start with the assessment of the tricuspid valve. The first part is to look at the mobility of the valve. The second part will be the assessment of the severity of the valve, and the third part to look at the repercussion on the function of the heart. So I will now move from this parasternal long axis view by tilting slowly my probe, and I will be in this position in a modified parasternal long axis view, where you can see is this enlarged right atrium, the tricuspid valve and the right ventricle. And if you have a look at the tricuspid valve, you will see that this septal leaflet at a restrictive motion, and I can say that this second leaflet is somewhat what I can qualify of knee openings. Now, in the same position, I will turn the color Doppler on, and you can see that there is a huge tricuspid regurgitation. This is frequent when you have tricuspid stenosis to also have tricuspid regurgitation, and this will have implication for the quantification. So, but let's move to the other view to see how we can also assess the tricuspid valve. If I continue and I will turn my probe to be in short axis view, you can already see here that there is a restricted motion of the tricuspid leaflet and an enlarged right atrium. Of course, you can use this view if you are well aligned to put your Doppler to assess the gradient through the tricuspid valve. But I will first recommend you to continue to have a look on the tricuspid valve, and I will propose you to go to the apical 4-chamber view. So we are now in apical chamber view. And this is easy to realize. This is the enlarged right atrium, the mitral stenosis, but this is not the topic of today. Enlarged right atrium, and you can have a look on the tricuspid valve here and the very restricted motion. And you can see it better if I move and in the same position. I will go to put a zoom on the tricuspid valve. So we are now in the zoom mode, and you can see that there is a restricted motion of the septal leaflet and this very nice knee opening of the lateral leaflet. So now we have to quantify the severity of the tricuspid valve, and we can put just through this valve a continuous wave Doppler. I will show you the result. This is important because if you look, this is obtained in the same patient just through the breath hold, because there is a huge variation in the flow through the tricuspid valve during the different part of the breath hold. So it's important, if you have to quantify it, you can make an average of the different measurements that we have. So let's say that we do the measurement here, just to explain you how we did, and you will see that the mean gradient is 14 millimeter of mercury. When we are above 5 millimeters of mercury, we consider that it's a severe stenosis. You can also use the PHT method that you will perform here. And when we have a PHT above 190 milliseconds, we consider that it's an elevated and it's a sign for severe tricuspid stenosis. So I told you just a few moments ago that you have huge variation during the respiratory cycle and that you have to make the average. The other solution is to make the measurement at end expiration. So I will ask my patient to stop breathing, so blow out and stop breathing. And this is the kind of measurement that we can obtain, and you will see that for each cardiac cycle we obtain exactly the same measurement. So now we have to look at another method that can be also used. It's to go for the continuity equation. You know that there is a lot of limitation when you use continuity equation, and for that I have to move back to my parasternal short axis view, and I will be just at the level of the pulmonary valve, and in fact my aim will be to take the measurement of the right ventricular outflow tract diameter quite at this level. This is not an easy measurement, and you can have a lot of error by doing this measurement. Just at this level you can put Doppler through the valve, and you have a pulse wave Doppler, and you can also measure the VTI, so having the measurement of the right ventricular outflow tract chamber, VTI through the pulmonary valve, and the measurement that you have through the tricuspid valve, you can perform a continuity equation and have the measurement of the tricuspid valve area. But be very careful. If you have a huge tricuspid regurgitation, you will have a wrong estimation of the tricuspid valve area. So the third part is to have a look at the repercussion. And the first repercussion, and I go back to my four-chamber view, it's to look at the right atrium. And you see here a very enlarged right atrium. This is the first consequence of a severe tricuspid stenosis. It is also important to go to the subxiphoid view, so I'm just in subxiphoid view, and I will go to the M-mode to the subxiphoid view to have a look at the inferior vena cava. And you see in this example that the inferior vena cava, you can take the measurement here, it's enlarged and there is no change with the breathing, and you see that it's quite dilated. It's above, I can take the measurement here, it's above 2.5 centimeter, what is the sign of elevated right atrial pressure. So in summary, I will tell you that you have three ways to assess the tricuspid valve stenosis. First, look at the valve. Secondly, look at the severity of the gradient, of the severity of the stenosis by the gradient through the valve. And the number to remember, it's 5 millimeters of mercury. And finally, you have to look at the repercussion, and especially on the right atrium and the inferior vena cava.
Lessons to be learned from this examination is that we have to take multiple views. We have to also ask the patient to have a breath hold during the acquisition of the transvalvular gradient. And finally, that we have to look not only to the valve morphology to assess the severity of the tricuspid stenosis, but also to look at the consequences of the disease on the right atrium and on the right ventricle.